Hi all, welcome to RAAONLINE. Today we are going to look at one critical care situation which might be a shock to any physician who is treating it. That is nothing but having a shock. What are the various hemodynamic alteration which happens in various type of shock? Shock in a simplest term is nothing but oxygen delivery which is supplied is less than the requirement. In short, the oxygen delivery is less than the oxygen requirement. Another important component of the shock is the perfusion, which is nothing but the blood flow or the cardiac output. When you talk about perfusion, it is nothing but the amount of volume which goes for a particular time over the amount of tissue. For example, you take a coronary blood flow. Normal coronary blood flow is about 50 to 80 ml per 100 gram per minute. So, you have the amount of blood flow, amount of tissue it supplies and the time. Normally, at the arterial end, oxygen and the nutrient comes and it goes and it gives the energy requirement for the tissue. Then oxygen is utilized. Then the carbon dioxide and the water waste comes back into the circulation and goes to the venous end. So, this part is the perfusion and this part is the oxygen delivery. In shock, both may be compromised, your perfusion as well as your oxygen delivery. At the arterial end, the partial pressure of oxygen is around 100 millimeter of mercury and the intracellular PaO2 is around 20 millimeter of mercury. So, there is a PO2 gradient of 80 millimeter of mercury which pushes the oxygen into the tissue. At the venous end, after oxygen utilization, the PVO2, partial pressure of oxygen in the venous is around 40 millimeter of mercury and the intracellular PO2 is around 100. So, the gradient is 30 millimeter of mercury. This gradient of oxygen is very important in oxygen delivery from the vessel to the tissue. Now coming to the other part, tissue perfusion. What is tissue perfusion? The relative amount of blood supply to an area or a body system. It decides the drug distribution. For example, when you inject thiopentone or some other drug, how much drug goes into the tissue depends upon the perfusion of that particular tissue. It can be a rapid to well perfused tissue like the brain and heart. Here, because of its rapid and well perfusion, there will be a high level of drug in the initial period. Some tissues can be slow or poorly perfused. It's like the fat. Here, there is going to be initially low level of drugs. And this perfusion can also be affected by the blood flow rate. For example, if it is vasodilated, the flow can be high, and if vasoconstricted, blood flow can be reduced drastically. Now, combining the oxygen delivery and tissue perfusion. The tissue perfusion is nothing but the cardiac output, which is normally around 4 to 5 liter per minute. The delivery of oxygen is around 1000 ml per minute and the oxygen consumption is usually for the whole body is around 250 ml per minute. So, the blood which comes from the left ventricle to the aorta is the arterial oxygen content. The arterial oxygen content is normally around 20 ml per deciliter and your cardiac output is around 5 liter. So, the total delivery of oxygen which is supplied to the tissue is around 1000 ml per minute, of which the tissue extracts oxygen of around only 25%. So, you remove 25% of 1000 ml. Your oxygen consumption is only 250 ml. Once this is the arterial side, then you go to the venous side after oxygen extraction. Here, the venous oxygen content is around 75%. The arterial oxygen content is 100%. After 25% extraction, venous oxygen saturation is around 75% and the venous oxygen delivery is around 750 ml. So, 1000 ml of oxygen comes in and 750 ml of oxygen goes back to the right side of the heart. Now, what is the definition of shock? It is a state of inadequate perfusion which does not sustain the physiological need of organ tissues. So, for the need of tissue, there is inadequate perfusion. It can be said as a physiological, I won't say physiological state, a pathological state characterized by significant systemic reduction in tissue perfusion resulting in decreased tissue oxygen delivery and insufficient removal of cellular metabolic product leading to tissue injury. Here, certain components are very important. Reduction in tissue perfusion, reduction in tissue oxygen delivery, insufficient removal of metabolic product, and finally, organ injury. These are all the various components of shock. So, what are the various type of shock? You have hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. These are the 4 types of shock. And coming to the instance of each type of the shock, hypovolemic is roughly around 20 to 30%. Distributive is the most common type, which is around 50 to 60%. Cardiogenic, usually seen with acute coronary syndrome, it is around 10 to 20%. And obstructive, it is around 5 to 8%. Now, coming to common pathological features of all type of shock. As I said earlier, your oxygen delivery does not meet the oxygen requirement. Your oxygen delivery is less than the requirement. Here, whenever oxygen is there, more ATP is produced. Normally, when oxygen is delivered in sufficient amount, it undergoes nice aerobic metabolism and lot of energy which is required, like ATP production will be really good. But when the oxygen delivery is inadequate, anaerobic metabolism takes place where the amount of energy delivered by the ATP is very minimal. By doing this, what happens is you produce lactic acid. Whenever there is anaerobic metabolism, your lactic acid goes up. As your lactic acid goes up, your pH comes down, acidosis sets in. So, whenever there is a shock, your lactic acid is high and your pH is low, acidosis sets in. Another important thing is, as I said earlier, oxygen, when demand is going to be high, the saturation is going to be low. So, you look at the central venous oxygen saturation with the sample taken at the right atrium. Usually, this oxygen saturation is what we measure, and usually in shock state, this oxygen saturation is low, and mixed venous oxygen saturation is more specific. This is the final endpoint of the venous system of the body. That will be also low, but in all scientific studies, central venous oxygen saturation is reflective of mixed venous oxygen saturation unless something happens in the right atrium or right ventricle. So, in cardiogenic and hypovolemic shock, there is increased oxygen demand. There is increase as much of oxygen extracted, it will be extracted. So, there is going to be increased oxygen. Whatever oxygen is available, it is going to be utilized there. This leads to decreased oxygen return to the heart. So, the amount of oxygen which goes via venous blood to the heart is reduced. So, your central venous and mixed venous oxygen saturation is going to be low. But in the case of distributive shock, there is definitely increased oxygen demand. But what is happening is the oxygen extraction is going to be low. The oxygen extraction is not happening. So, the amount of oxygen returning via the venous system to the heart is increased. So, this leads to increase central venous and mixed venous oxygen saturation. So, the distributive shock is different from other form of the shock by having increased mixed venous and central venous oxygen saturation. All other parameters will be almost similar. Now, coming to hypovolemic shock. Hypovolemic can be hemorrhagic, which can be traumatic or non-traumatic. In hemorrhagic, it is the blood component which is lost. You have blood, plasma and body fluids. Blood is lost in hemorrhagic shock. Here, it can be due to a GI bleed, menstrual disorder, internal bleeding like something in the esophagus or in the brain or retroperitoneal bleeding. Those things, again, the blood is lost, or an external bleeding like scalp injury or fracture which is penetrating, or some skin laceration, huge skin laceration or something which is an external bleeding. Now coming to non-hemorrhagic, non-traumatic. Here body fluids will be lost. You can have gastrointestinal loss through nausea, vomiting and diarrhea. Third space shifting like ascites, or it can happen in trauma also. Abnormal fluid loss from the skin with high temperature and sweating. These are the different ways in which body fluids can lose and lead to hypovolemic shock. And there is another entity where non-hemorrhagic traumatic, where plasma gets lost. This can happen with burns injury. Coming to the clinical features and diagnosis, there is going to be loss of body fluid, plasma and blood. Here the first sign is going to be hypotension and tachycardia. There is no volume in the circulation and your blood volume comes down. There is going to be hypotension. As a compensation, you are going to have tachycardia, and there are signs of tissue hypoperfusion, which is very similar to all shock. Altered mental state, mottled, clammy, pale skin, oliguria and elevated blood lactate. And it is characterized by external or internal fluid loss leading to organ failure. Here, the central venous oxygen saturation is going to be low and your cardiac output is also low because the volume is lost. Most important thing is, because of hypovolemia, your central venous pressure is low. On the echocardiogram, will show small cardiac chamber with normal or high contractility. The volume in the heart is less and there will be kissing ventricle. Now coming to the pathophysiology, there is loss of blood volume. So the amount of blood which goes to the heart is reduced, which is decreased preload. The volume in the heart is less, decreased stroke volume. There is going to be hypotension. So to compensate for this, there is going to be widespread vasoconstriction, increased contractility of the heart, and your heart rate also increases. These are all the various compensatory mechanisms which happens with hypovolemic shock. And to establish the diagnosis, you look at the serum lactate, and in the ABG, your PO2 will be low and there can be acidosis. And if you look at the hemoglobin and hematocrit, due to blood loss, it will be reduced. And you have to do a focus assessment sonography in trauma. Like you have to know which area to scan and you have to scan accordingly to locate the site of bleeding. Now coming to the management. Here the primary goal is to stop the bleeding or stop the fluid loss. Whatever happens, you have to stop the volume loss. In case of surgical bleed, you have to take care of the bleeding. You have to control the bleeding, or sometimes extreme step of angiographic embolization of that bleeding vessel can be done. Coming to hemodynamic management, here your goal is first to maintain the arterial pressure. What is lost? The fluid and blood is lost. So you go ahead with fluid resuscitation. And goal is to maintain your arterial pressure. Without traumatic brain injury, you try to maintain a systolic arterial pressure of 80 to 90 millimeter of mercury. But if there is a traumatic brain injury, you still have a try to maintain a still higher pressure, systolic blood pressure of around 120 millimeter of mercury. If by giving volume you are not able to maintain the arterial pressure, consider a small dose of vasopressor. You can start noradrenaline at a dose of 0.1 microgram per milligram per minute. Then again you titrate the fluid, go look for indices of fluid responsiveness like your stroke volume variation or your IVC diameter. Look for various indices of volume replacement and also your cardiac output monitor. You can look as cardiac output marker of tissue oxygenation. Now coming to coagulation management. If bleeding is going to be excessive, try tranexamic acid first, 1 gram IV followed by IV infusion of 1 gram over 8 hours. Your coagulation target is you have to maintain the hemoglobin between 7 to 9. Your PT and PTT should be 1.5 times of normal. Platelet should be more than 50 into 10 power 9 per liter and fibrinogen should be between 1.5 to 2 gram per liter. And you have to adjust your blood product to maintain this coagulation target and not to forget to treat acidosis, maintain normal temperature and give calcium and maintain the ionized calcium at a level of 1.1 to 1.3 millimole per liter. Now coming to blood product management, here first is your RBC. How will you decide how much blood to be given? Your desired hemoglobin into body weight into 3. For example, you want to raise the hemoglobin from 8 to 10, which means 2 hemoglobin rise. The body weight, assume it is around 60 and into 3. So it comes to around 360 ml. So the amount of blood which has to be transfused is around 360 ml. And coming to platelet, it is roughly around 10 to 20 ml per kilogram. And it is the same for fresh frozen plasma, 10 to 20 ml per kilogram. Coming to cryoprecipitate, which we administer in case of excessive bleed, it goes around 5 to 10 ml per kilogram. Usually 10 units, approximately 200 ml will be administered. Now coming to the second type of shock, cardiogenic shock, where heart as a pump has failed and it does not pump adequate blood into the circulation. Here almost all signs are very similar to hypovolemic shock, except that your central venous pressure is going to be high. Hypovolemic, the central venous pressure, the amount of blood returning to the heart is less, but here the heart has failed as a pump and there will be volume loaded inside the ventricle and your CVP is going to be very high. Here, if you look at the echocardiogram, the ventricle will be dilated and there is poor contractility. And symptom wise, the patient is going to have low cardiac output syndrome, there is inadequate oxygen transport and it is caused by myocardial infarction, the usual common cause, end-stage cardiomyopathy, advanced valvular heart disease, severe myocarditis or severe cardiac arrhythmias. Now coming to the criteria to say patient has cardiogenic shock. First is there is persistent hypotension. Your systolic blood pressure is less than 90 millimeter of mercury or your mean arterial pressure is 30 millimeter of mercury less than the baseline. Cardiac index is less than 1.8 liter per minute per meter square without inotropic support or it is less than 2.2 liter per minute per meter squared with inotropic support. And your filling pressure is elevated. Your pulmonary capillary wedge pressure or left ventricular end diastolic pressure is greater than 18 millimeter of mercury or your CVP or right ventricular end diastolic pressure is greater than 10 millimeter of mercury. And what are the symptoms of cardiogenic shock? First is pulmonary congestion, increased JVP. In case of coronary artery disease, patient might have angina. There will be organ failure and organ dysfunction. Your urine output is going to be low and patient have a cool peripheries. The diagnosis, again serum lactate, ABG, there is going to be acidosis. And in case of cardiogenic shock, you look for cardiac biomarker, troponin and basal neuritic peptide. And X-ray and echo will play a major role in cardiogenic shock. This is a normal chest X-ray and once cardiogenic shock develops, the patient will have cardiomegaly and pulmonary hypertension. And in case patient has congestive cardiac failure, there is going to be prominent upper lobe vessels, cardiomegaly will be there pleural effusion sets in, and curly B line will happen with interstitial edema, and widespread alveolar edema can lead to bat wing appearance. These are all the various X-ray findings with cardiogenic shock. Now coming to echocardiographic parameter, if you look at the IVC diameter, the IVC is widespread and IVC is dilated nicely. Normal IVC diameter is around 1 to 2 centimeter and it collapses nicely. But in case of cardiogenic shock or congestive cardiac failure, the IVC will be dilated and does not collapse. It will be more than 2 centimeter. And if you look at the ventricle, there is hardly any movement of ventricle and the ventricle is severely dilated. And cardiac MRI, here you can see the right ventricle is too much. Normally, the right ventricle is less than the size of the left ventricle. As right ventricle failure develops, it will become equal in size, or if greater than size of left ventricle, it is severe RV dysfunction. Now coming to diagnosis and management of cardiogenic shock. The first, in case of ischemic heart disease, you have to do an angio and you have to revascularize a patient. Here, angiography become the investigative modality, and you have to, even if you place a stent or do the surgery, you have to maintain the patency with antiplatelet and anticoagulant. Now coming to afterload. Here you have to look at the mean arterial pressure and systemic vascular resistance. The afterload, usually you look at the blood pressure and systemic vascular resistance, and normally you try to maintain a mean arterial pressure of 65 to 75 millimeter of mercury, your systolic blood pressure between 90 to 140 millimeter of mercury, and your SVR you maintain around 900 to 1600 dynes second centimeter per minus 5. For increasing your afterload, you use norepinephrine or vasopressin. For decreasing the afterload, you use vasodilators or nitroglycerin. Now coming to preload. The preload can be measured by your central venous catheter or the pulmonary artery catheter. The right atrial pressure normally around 4 to 8 millimeter of mercury, and the pulmonary capillary wedge pressure is between 10 to 14 millimeter of mercury. To increase the preload, you use crystalloids or blood. To decrease the preload, you use diuretic or dialysis. Now coming to contractility, you look at the echocardiogram to assess the cardiopulmonary index or cardiac index. The normal cardiac index is around 2.2 liter per minute per meter squared, and your cardiopulmonary index is around greater than 0.4 Woods per meter squared. Here, to improve contractility, use dobutamine, levosimendan, calcium channel sensitizer, phosphodiesterase inhibitor milrinone can be used, adrenaline can be used, and finally, none of the pharmacological agent works, you can go for mechanical support with LVAD or IABP or impeller pump. Coming to heart rate, the ideal heart rate will be around 50 to 80 beats per minute. To increase the heart rate, you can use atropine or epinephrine. To decrease the heart rate, you can use beta blocker, cardron, and in case the rhythm is really abnormal, you can go for cardioversion. Now coming to obstructive shock. Here it is almost all the clinical features are very similar to other type of shock, but here there is obstruction and there is high central venous pressure. The heart is compressed by fluid or hair. Your thoracic cavity is engulfed by hair or fluid, so that the heart cannot expand and give a adequate cardiac output. Here it is characterized by a blockage in blood flow caused by massive pericardial effusion, cardiac tamponade or tension pneumothorax. If you look at the echocardiogram, in case of pulmonary embolism or pneumothorax, there is going to be dilated right ventricle and a small left ventricle. So in case of tamponade, there will be pericardial effusion, small left and right ventricle and dilated inferior vena cava. Coming to etiology, in case of cardiac tamponade, it is going to be impaired diastolic filling. In case of massive pulmonary embolism, there is going to be increased right ventricular afterload, which pushes the septum to the left side and compromises the left ventricle function also. And in case of tension pneumothorax, it is going to be obstruction of venous return. Here, you can take the heart as a pump and this blood vessels which comes from the heart as pipe and venous system as the tank reservoir. You have the pump, pipe and the tank. In case of tension pneumothorax, there is air in the thoracic cavity and your heart, lung, RV, everything is engulfed in the air. So, there is decreased pipe flow. The pipe flow is not adequate, but you have a dilated tank. The reservoir is dilated and enlarged. The tone is not much altered. This is tension pneumothorax. In case of pulmonary embolism, your right ventricle output is affected. There is a clot which prevents the blood from the right ventricle going into pulmonary and your septum, the right enlarges and pushes the septum towards the left ventricle and your left ventricle output is also compromised. So, the pipe flow is reduced again, but the lung and the tone is not altered much because right ventricle is affected. There is increase in tank size, that is your IVC is dilated. In case of cardiac tamponade, there is blood or fluid around the right and left ventricle. Your pipe supply is decreased. The tone and lung are not much altered. Again, the IVC is dilated. These are the different features which happens with obstructive shock. Now, coming to the diagnosis. The first and foremost is your clinical examination. Here in clinical examination, compared to other type of shock, there is going to be an acute hypotension. Suddenly, if the tension pneumothorax happens, the fall in blood pressure will be so drastic. It will be so fast. The patient will deteriorate very rapidly. There will be hypotension and tachycardia, but the hypotension happens in a span of 30 to 40 seconds. Next, you have to do a rush protocol, which is nothing but rapid ultrasound in shock. Here, you look at the tank IVC, heart, pump and the aorta as the pipe. Blood vessels you have to look at. Then you can do for radiological imaging to look at what happened to other part of the body. Now, coming to rush protocol, if you look at the heart chambers, okay, this is the right ventricle, this is the left ventricle, this is the image we see, and in the echocardiogram, this is the natural image, right ventricle and the left ventricle. And in case of here, if you have some obstruction like it is caused by pericardial effusion or thing, you can see the fluid engulfing the right and left ventricle, that is pump. In case of tank, you look at the IVC diameter. If pathological, you can see a dilated IVC. Here you can look at the collapsibility also, what happens during inspiration and expiration. And pipe, you have to look at the IVC and aortic. Here you can look at the deep vein thrombosis or aneurysm or something which happens in the pipe, major blood vessels of the body. Now, coming to the management. The first and foremost is you have to take care of the airway. You have to intubate the patient as soon as possible and you have to treat the underlying cause. If it is a tension pneumothorax, you have to go for a chest tube insertion. Pericardial tamponade, you have to do a pericardiocentesis, and in case of pulmonary embolism, you have to anticoagulate the patient. And don't forget the fluid resuscitation. Now, coming to the last type of shock, which is distributive shock. Here, the clinical feature is almost similar to other type of shock, but you have widespread vasodilatation. Here, as I said earlier, there is going to be normal or high cardiac output or high central venous oxygen saturation. Here, it is characterized by hypovolemia and hypotension. It is a result of vasodilatation and release of inflammatory mediators. Echocardiography, here the heart chambers will be normal or slightly reduced and usually the contractility is well preserved. Here it is caused by 4 types. It can be septic, anaphylactic, anaphylactoid or neurogenic. In septic, it is capillary leakage. In anaphylactic and neurogenic, it is vascular tone dysregulation. Now coming to the criteria of septic shock. First, let us look at systemic inflammatory response syndrome. Your heart rate will be greater than 90 beats per minute. The temperature can be greater than 100.4 Fahrenheit or less than 96.8 Fahrenheit. The respiratory rate can be greater than 20 per minute or the PaCO2 is less than 32 millimeter of mercury. The WBC greater than 12,000 per cubic millimeter or less than 4,000 per cubic millimeter, or your band form is greater than 10%. If any of these 2 or more criteria is present, it is called systemic inflammatory response syndrome. If this systemic inflammatory response syndrome is present in addition to suspected or present source of infection, it is called sepsis. And this sepsis in addition with lactic acidosis or the systolic blood pressure less than 90 millimeter of mercury or the drop of systolic blood pressure of greater than 40 millimeter of mercury from normal, in addition with organ dysfunction or hypotension or hypoperfusion, it is called severe sepsis. So what is septic shock? This severe sepsis with hypotension despite adequate fluid resuscitation and organ injury, it is called septic shock. So you have a pathogen, let it be bacteria or something. Your cells gets activated, your WBC and macrophages get activated and they release the inflammatory mediators, cytokines, interleukins, everything gets released, and this inflammatory mediators calls leaky vessels and they can be small blood clots which leads to thrombosis where platelet plays a major role, and there is widespread capillary dilatation which leads to hypotension and your organs, brain, lung, heart, liver and kidney will be affected. So coming to the pathophysiology and symptom, there is going to be WBC recruitment, the vessel wall diameter increases and there is going to be increased leakiness, organ damage will be there. Initially in sepsis, there will be high cardiac output and tachycardia, and in the later stage, your cardiac output comes down, and later from warm skin due to peripheral vasodilation becomes cold skin. The diagnosis for usual shock, you go ahead with lactate, ABG, burnt creatinine, but with regard to sepsis, there are certain biomarkers which we look at: CRP, erythrocyte sedimentation rate, procalcitonin and blood culture. With regard to procalcitonin, if it is between 0.05 nanogram per ml, it is local infection. If it is 0.5 nanogram per ml, it is sepsis. If it is 2 nanogram per ml, it is severe sepsis, and it is septic shock when it is greater than 10 nanogram per ml. With regarding to antibiotic algorithm, if it is greater than 0.5 nanogram per ml, antibiotic is strongly encouraged. If it is between 0.25 to 0.5 nanogram per ml, antibiotics can be encouraged. If it is between 0.1 to 0.25 nanogram per ml, antibiotic is usually discouraged. And if it is less than 0.1 nanogram per ml, antibiotic is strongly discouraged. Like we have enzyme profile for acute myocardial infarction, you have inflammatory mediators in septic shock. Usually most of the inflammatory mediator, tumor necrosis factor or interleukins will return to the baseline within 48 to 72 hours. Your procalcitonin and lactate will take some more time. It usually takes around 3 to 4 days, and CRP might take weeks to come back to normal. Now coming to the management. Here you have to go for a 3-prong attack. The first is hemodynamic management. Here you go with SO/SD paradigm. Here you salvage, optimize, stabilize and then de-escalate. You try with fluid and vasoactive agent. And modulation of host response, you try steroid or vasopressin. And infection management, you go with antibiotics and source control. Now coming to anaphylactic shock, here you have an exposure to allergen, which might be a food, chemical or a insect bite. You have IgE, which is related, which combines with the mast cell and release the inflammatory mediators. Your histamine, leukotriene, cytokines, thromboxane, everything gets released, and this goes to the body circulation and then all the organ system, your central nervous system, kidney, heart, blood vessel, gastrointestinal, lung, airway and skin will be affected. So what are the various manifestations of anaphylactic shock? Central nervous system, it can occur in 10 to 15% of reaction. Here the symptom is going to be anxiety, headache, dizziness, confusion, tunnel vision and fainting. Cardiovascular system, it can happen in 30 to 45% of reaction. The patient might have chest pain, low blood pressure, rapid heart rate but a very weak pulse. Coming to gastrointestinal tract, again it is in 30 to 45% of reaction. Here the patient might have nausea, abdominal cramp, vomiting or diarrhea. And coming to airway, this is the most important thing. There it is going to be in 80 to 90% of the reaction. Here the patient might have tightness in the chest or even airway tightness, swelling of the throat, hoarseness and scratchy throat. The patient might have difficulty in breathing. There can be wheeze and chest tightness. Coming to skin, it also happens in 80 to 90% of reaction. There will be urticaria, itching or flushing skin. There will be swelling of lips, lung, throat and face. Now coming to management, here you have to take control of airway, breathing, circulation and look for disability and what exposure has happened. You look for acute onset of illness, life-threatening airway or breathing or circulation problem and look for skin changes. You call for help, make the patient lie flat and most important thing which you do is raise the patient leg and you can try IV or IM adrenaline. IV adrenaline, likewise a physician opinion, IM adrenaline can be given by paramedics. Then if skills and equipments are available, you establish airway, give high flow of oxygen, go for fluid challenge and antihistamine can be tried and the monitors which should be used is pulse oximetry, ECG and blood pressure. Now coming to neurogenic shock. What is neurogenic shock? There is a spinal cord injury above T6. At the level of T6 there is some injury. Your sympathetic tone is altered. There is disruption of sympathetic tone which leads to venous and arterial vasodilatation. Both venous and the arterial system gets vasodilated which leads to decreased preload, which means the stroke volume is reduced. And when stroke volume is reduced, your cardiac output is going to come down. This disruption of sympathetic tone leads to unopposed parasympathetic activity. Your parasympathetic is overactive, which leads to decreased heart rate. Normally, cardiac output is multiplication of stroke volume and heart rate. In neurogenic shock, you have decreased stroke volume, you have decreased heart rate. So, your cardiac output is going to fall drastically. And this fall in cardiac output leads to hypotension. Here, hypotension, organ dysfunction, there is going to be bradycardia. Usually in all other type of shock, you might see a tachycardia. But in neurogenic shock, you will have bradycardia. And there will be poikilothermia, which is inability to regulate the temperature of the body. The treatment, you have to go for a vasopressor to increase the pressure, lot of IV fluids and atropine to counter the bradycardia. Finally, another different type of shock where oxygen delivery can be compromised without affecting volume, which is called the dissociative shock. Here, as I said earlier, oxygen delivery to the tissue will be compromised. Not necessarily the blood flow is compromised, but the hemoglobin which carries the oxygen is compromised. Here, inability of the hemoglobin molecule to give up oxygen to the tissue. So, oxygen delivery is compromised because of hemoglobin, not because of tissue perfusion. Here, the etiology is carbon monoxide poisoning, methemoglobinemia or dyshemoglobinemia. Here, as I said earlier, the tissue perfusion is adequate, but oxygen release to the tissue is abnormal. Early recognition and treatment of the cause is the main course of action in dissociative shock. Carbon monoxide poisoning, it binds to hemoglobin 100 times more than oxygen. So, there is decreased oxygen delivery because hemoglobin is bound tightly to carbon monoxide. Another important cause is methemoglobinemia, which converts the reduced ferrous state to oxidized ferric state. Ferric cannot bind to oxygen, but ferrous bind to oxygen. It can happen with nitrate or trimethoprim sulfamethoxazole combination, dapsone, benzocaine and pesticide. Here the symptom is going to be headache, dizziness, fatigue, confusion, loss of consciousness and dyspnea, and the treatment is with methylene blue, which converts ferric to ferrous form. So, finally, to compare the hemodynamics of various type of shock. Most of the time it is going to be hypotension and tachycardia. What happens to other parameter? In cardiogenic, your cardiac output is low. Heart as a pump fails and fails to send adequate cardiac output. Your SVR will be high. Your pulmonary capillary wedge pressure or left ventricular end-diastolic volume is going to be high and mixed venous oxygen is low. In obstructive, your cardiac output is low, SVR is high, pulmonary capillary wedge pressure is high, again your mixed venous oxygen is low. In hypovolemic, your cardiac output is low, SVR can be high, your pulmonary capillary wedge pressure, your preload to the heart is reduced, so it is going to be low, and mixed venous oxygen it is low. Coming to neurogenic, your cardiac output is low, SVR is low, it doesn't have any effect on pulmonary capillary wedge pressure, and in neurogenic, as I said earlier, there is going to be bradycardia. That is a distinguishing feature of neurogenic shock, and your MbO2 is low. In septic, initially there will be high cardiac output, at later stage or in the final stage the cardiac output will be low. SVR is drastically reduced in sepsis. Your pulmonary capillary wedge pressure or left ventricular end-diastolic volume may be normal or low, and the MeO2 initially will be high and later it will be low. Anaphylactic shock, again your cardiac output will be high, SVR is too low, and your pulmonary capillary wedge and end-diastolic volume can be reduced. Your mixed venous oxygen saturation will be normal or high. In dissociative, your cardiac output is increased, SVR is slightly increased, your pulmonary capillary wedge pressure is not altered, and the mixed venous oxygen saturation is low. These are all the hemodynamic changes with various type of shock. So, to conclude, here it is an imbalance between oxygen supply and demand. Shock is nothing but an imbalance between oxygen supply and demand. There are 4 types of shock: hypovolemic shock, distributive, cardiogenic and obstructive. And in case of hypovolemic and distributive, it is the volume which is affected, and in case of cardiogenic and obstructive, it is the cardiac output which is affected. Here the output, it can be cardiac or extracardiac. In volume, it can be the loss of body fluid or the shift of body fluid. In case of hypovolemic shock, it can be traumatic hypovolemic, like burns, you lose the plasma, or you can lose the body fluid like nausea, vomiting, diarrhea, or in case of blood, it can be a traumatic hemorrhagic or surgical hemorrhage. It would lead to lot of blood volume. Coming to distributive shock, it can be septic where your permeability is altered, or it can be an anaphylactic or anaphylactoid or neurogenic where the vascular tone is altered. Widespread vasodilatation will be there. And coming to obstructive, determined by right heart where lesser circulation is altered, determined by afterload where greater circulation is altered, or determined by preload which depends upon various location. Coming to cardiogenic, it can be myocardial pump failure where your myocardium is altered, tachyarrhythmia where your conduction system is altered, and your valvular disorder, acute insufficiency or decompensated stenosis leads to cardiogenic shock. Thank you. Try to avoid shock in your practice.